Okay, Assalamu alaikum. Good morning, everyone. Hopefully you're having a good time here. So my talk is going to be about headache cocktails. The first time I heard about this term when I was in my residency, when my attending physicians or consultant asked me to give one of the patients with headache the cocktail. So I wasn't sure what did he mean by the cocktail. At that time, I looked it up, it was 3 medications. So we're going to go through that, and we're going to see what kind of cocktail we're going to bring and discuss. So the main objective is to talk about the treatment of headache in the emergency department. And depending on the type of headache, the treatment will be based on the type of headache we're facing in the emergency. There are many different ingredients in that cocktail or medications, 20, 30, maybe more. But what is the best cocktail recipe to give it to a patient with headache? So start with a case, 28 years old female complaining of right-sided headache and 1 episode of vomiting. The headache started gradually over the last hours. No other complaints. She had several headaches similar to that headache before in the past. Her vital signs and examination is normal, including the neurological exam. She took acetaminophen at home, but no improvement. So just show of hand, what treatment would you give? First, ibuprofen, show of hands. Okay, not that many. Thank you, Abdurrahman al-Bayb. B, IV acetaminophen. Show of hands. Okay. IV metoclopramide. Show of hands. Okay. Dexamethasone. Show of hands. And last thing, morphine. Show of hands. Okay. Who would give all of these 5? Again, show of hands. Oh, interesting. Okay. So as I said, the types of headache or the classification of headache is very important for us in the emergency department. So classically, there are 2 types of headache, primary and secondary headache. And the primary headache or the idiopathic headache is basically, it's the headache is itself the disease. And the secondary headache, it's a symptom of an underlying problem or disease. For example, a bleed in the brain or a tumor in the brain. In the primary headache, there is no organic lesion, and the treatment is just for the headache itself. And for the secondary headache, it's basically that the underlying cause that you will be treating. Subarachnoid bleed, a subdural hematoma. So in my talk, we're going to focus mainly on the primary headache or the idiopathic headache. First of all, you're going to have to go through the history and physical exam. And mainly you're looking for the red flags when you're asking these questions to your patients. And make sure that you don't miss those red flags because disasters would happen after that. So things such as the sudden onset headache, a headache with seizures or fever or neurological deficits, headache, thunderclap headache, headache which started during exercise, headache that wakes the patient from sleep at night. So primary headache is classically categorized in 3 types: tension headache, migraine, and cluster headache. The most common is tension headache, but usually those patients, they don't go to the emergency. Most of the patients we see in the emergency are the migraine headache. Tension headache is the usual headache we have. Probably all of us had it before in the past. Usually stays for like a few days or weeks, and it relieves easily. Migraine, usually it's more severe, intense, pulsatile in character, and mostly localized on one side. Cluster headache is rare compared to the other types. Usually it's excruciating pain in unilateral in one of the eyes, and it usually wakes the patient up from sleep at night. So what are the medications that we use to treat headache? There are too many, as I mentioned. So one of the main medication, intravenous fluids. IV fluid is considered the medication. And the idea or the verdict is that most of those patients are dehydrated, and this dehydration will trigger the headache. And to fix that, just hydrate those patients. So IV hydration is used most commonly in the emergency departments to treat the headaches of unclear etiology or migraines. also as part of the cocktail. And most of these patients were vomiting, had decreased oral intake. And this question has been looked at in one of those studies by Balbin and his colleagues. They looked at the intra-IV fluids for migraine in a post-hoc analysis of clinical trial data. And in that study, they evaluated IV fluids with metoclopramide versus metoclopramide alone. And they found no difference in terms of the efficacy of relieving the pain. But IV fluid is not a bad thing to give to a patient unless he has some volume overload problems or CHF. But if you think the patient is dehydrated, give him IV fluid for his headache. Antidopaminergic agents, one of the best classes for symptom management. Side effects, drowsiness and extrapyramidal side effects. Drowsiness is very common in those patients, and extrapyramidal side effects happens usually with faster infusion of the medication. Mostly there are three classes: butyrophenols, phenothiazine, and the third class is metoclopramide. It's a class on its own. Phenothiazine, the most studied medication is prochlorperazine, which is basically Stimatil, the brand name. It's the most commonly used medication in the US. I don't think we use it very often here in Saudi. Metoclopramide is the most commonly used medication here, at least in Riyadh, that I'm aware of. And it's very commonly used as part of the cocktail. And there is a strong literature to support those two medications, prochlorperazine and metoclopramide. Acetaminophen, useful in headache therapy. Good thing is minimal adverse events. And actually it outperforms triptan class, which is one of the classes that we use for treatments of headache. Usually at 60 minutes, IV acetaminophen is better. But the problem is very short acting. So in 120 minutes after 2 hours, it's not that effective. So you have to give it again as a second dose, a third dose. NSAIDs. My colleague at Al-Bayed, he said that it's bad, and probably he put the nails in the coffin. And he's right, because of the complications and the side effects that happens with NSAIDs. But the evidence here strongly supports its use in headache, not as the antidopaminergic and acetaminophen. And the most commonly studied medication is the ketorolac. It's one of the most commonly studied. And it's good for as a first-time treatment as an oral medication at home. Serotonin receptor agonist, triptans. Primarily used in outpatient setting. We don't use it often in the emergency. The commonly used agent is sumatriptan, which is usually given subcutaneously. The number needed to treat is 2.5, which is pretty good. But the problem is had, again, potential side effects: chest pain, shortness of breath, flushing, worsening headache, with a number needed to harm of 4. And it takes time to kick in. So if you give it in the emergency, it will take 2 or 3 hours to kick in. So better to use IV medication compared to triptans. Diphenhydramine, the medication that knocks the patient out, makes them more drowsy. So how useful Benadryl or diphenhydramine for treating migraine or headaches? Actually, it doesn't help for the pain. It has been shown that there is no benefit for the pain. But if you use antidopaminergic medication such as metoclopramide, you should add diphenhydramine to prevent the extrapyramidal side effects, especially if you're going to give 2 doses or more of metoclopramide. You give the first dose 10 milligrams, and then you give a second dose of 10 milligrams, then you should start diphenhydramine. Looking at the literature also for headache treatments, so I have to be thorough. So I found those treatments for headache. الفري, which is basically تنسيم اللي في الراس. And they have the definition here, which is هواء بارد يدخل الراس بين الجمجمة والجلد. So it's a cold air that goes into between the skull and the skin, which is interesting. So anyways, I looked at the literature, no language restrictions. There was no established RCTs or observational studies or case reports supporting that. And disclosure, there is no conflict of interest with any pharmaceutical companies or traditional healers. High flow oxygens. High flow oxygen is used for one of the types of headaches that I've mentioned. Do you know which one of them? Cluster headache, yes. So cluster headache is very excruciating pain. It's just unilateral. It's like someone stabbing your eye. And usually it wakes people from sleep, and that makes them not to go to bed and become more insomnic. So if you have a patient with known history of cluster headache, or you suspect cluster headache as the problem, add oxygen to your treatment. Opioids. We like to use it for pain. It's very good for improving the pain for patients. It's used more than 50% in the AD for headache, so it's very commonly used. But there are significant numbers of alternative agents that I already spoke about some of them. And several societies recommend against opioids for headache. And actually it may cause worsening of the headache, increase frequency of revisits, and decrease efficacy of the other medications such as the antidopaminergic. So for patients with primary headache, you should avoid them as much as possible. Use the other medications. Steroids. Recent RCTs do not suggest efficacy of steroids for headaches, but they can reduce the risk of recurrence within the first 72 hours. So it's used for prevention, not for the acute attacks. Propofol, the favorite medication for Michael Jackson. It has been studied in small studies, and its efficacy for headache improvements is not well established, but it's good for refractory headache. Once you tried all the other medication, you can use Propofol. And it may be useful. But be careful with Propofol because it may kill your patients. You have to have a close monitor with on the patient and make sure that he doesn't go into hypotension, respiratory depressions. So these medications should be given in the resuscitation area or in the ICU. And it works well for patients with headache. Other medications. Magnesium. It may help, but there is no RCT to support that, but you can use it in refractory headache. Ketamine. Now it's becoming more commonly used for pain treatment. A small dose, analgesic dose of 0.1 to 0.3 milligrams, IV slow push, may be useful in refractory headache. So you can add it in your armamentarium. So there is a society in America, it's called the American Headache Society, in which they have guidelines for headaches. And there are different societies now, it's becoming in the States, Abdominal Pain Society, Abdominal Compartment Syndrome Society, I don't know, maybe we're gonna have a chest pain society. And they had all these medications studied, and they had a list of medication based on the available literature and the evidence. And they level it based on the recommendation according to the guidelines. So level A, level B, and level C. And level A, there is no medication that really reaches the level A of evidence. Level B, metoclopramide and prochlorperazine are the two medications that's really effective in headaches, primary headaches. Sumatriptan is effective, but as I said, it's subcutaneous, it takes a long time in the emergency. Other medication, but it's class C, acetaminophen, and NSAIDs, and antipsychotic, they may work. Avoid diphenhydramine in headache treatment, but it's the diphenhydramine, as I said, it helps in reducing the extrapyramidal side effects. Opioids, lidocaine, IV, and octreotide, you should avoid them in primary headache. Dexamethasone, ergotamine, ketamine, Propofol, there is no recommendation. There is no good data or evidence to support that. Dexamethasone is the most studied steroid for prevention. So what cocktail should you provide for those patients? As a first line, what I usually give, metoclopramide or prochlorperazine as a first line. NSAID, IV ketorolac for the patient who doesn't have any contraindication, I think it's fine. Acetaminophen PO or IV. IV fluid for the patients who you think or you suspect that he's dehydrated. Dexamethasone if you're trying to prevent as a prophylaxis for the second attacks or third attack. If all of these fail, then you can go to the second line, such as Propofol, ketamine, or a nerve block. I usually use ketamine as a second line. When you discharge the patient, you can put him on NSAIDs, acetaminophen, and most importantly, antidopaminergic. PO metoclopramide is what we usually give, and with the discharge instructions with that. So in summary, for benign headache, a specific diagnosis is not mandatory in the emergency. You don't have to make the diagnosis for the primary headache. You have to rule out the bad things, the bad killers. Antidopaminergic have the strongest literature support. So metoclopramide is one of the first line medication that you're going to use for any patient with primary headache. Diphenhydramine should be used if you're concerned about extrapyramidal side effects. A combination cocktail of medication is advised. It works more fast and it's more effective. Steroids likely will decrease the recurrence of headache. And lastly, avoid opioids as much as possible in headache patients. Thank you.